Before starting the webinar, we have a message from our dean, Dr. V.B. Karadi sir. The Samiko is there. So, I resolved it. I request to all the participants, please off your mic. Dr. Nalin Sharma, off your mic. Now it is clear, I think. Okay, there is no echo. So we have a message from our Dean, Dr. V.B. Karadi sir, College of Veterinary Science, Navsari Agriculture University, Navsari. Dr. V.B. Karadi sir, please.
Good morning to all. Hope you all are the place in COVID-19 situation. We all know that due to the coronavirus, we all are under the lockdown period, which has affected the education of the. But to mitigate this issue, Navsari Agriculture has developed E-class facility for the students under the guidance of Honorable Patel and that all the teachers, veterinary college use this facility and complete many curriculum in the lockdown.
I request participants to please off your mic. Dr. Dinesh, please off your mic.
And also successfully completed the online examinations. In addition to this, our teachers, Dr. Deepak Shukla and Dr. Lalit Modi, also started NAU Webinar Series 2020 on the various topics on clinical aspects for the benefit of undergraduate and postgraduate students and veterinarians as well as teachers. I appreciate that the efforts are made by Dr. Suthar and Dr. Modi to use this critical COVID-19 period very efficiently to improve the knowledge of the students and veterinarians through the digital provided by the department of the university. The NAU website is not only for the Gujarat students and veterinarians, but also almost useful globally as per the participant registered in various countries. I congratulate Dr. Suthar and Dr. Modi for the success of the NAU Webinar Series 2020 and wish them the best of the luck for the future endeavor. Thank you.
Thank you, sir, for your motivation as well as the best wishes. Now I request Dr. Jatin Patel to please start the webinar. I again request to all the participants, please off your mic. It will produce the echo in the system. Please off your mic as well as the video. Dr. Jatin Patel, please start the webinar.
Good morning to all of you. Today is a very good day. Today is the Guru Purnima, and I like to thank all my teachers who have provided me encouragements and knowledge in my life. Now with this word, today we'll start our webinar, use of antibiotic in the veterinary practices. Again, before starting, just I like to acknowledge whatever the infrastructure provided by the Navsari Agriculture University. I'd like to thank the Honorable Vice Chancellor Dr. S.R. Chaudhary, Dr. V.V. Kharaise, Dean of this college, and all other faculties who are directly and indirectly organizing these all events and helping with the technical bit. Okay, and now coming to the topic, use of antibiotic in veterinary practices. See, today's topic. In today's topic, we'll see this use of antibiotic in a veterinary practice as a pharmacological perspective. Now, what is pharmacological perspective? We'll see after a few slides. Now, before that, going to the main topic, we'll like to see how the bacteria is evolving. And you can see in the photo, this is one plate. It is called petri dish. Already in the UG section, already you have seen the petri dish, but this is not an usual petri dish what we can which can handle in a hand. This is very quite big petri dish, about size of 2 feet to size of 1 minute. It is around 2 feet to 4 feet. See, the size is 2 feet by the 4 feet, and this whole petri dish is divided into some sections that you can see the transverse line on it. And in this transverse line, see the antibiotic ciprofloxacin has been poured in the agar, and we can see that the ciprofloxacin has been having the concentration 0 at both the end, and it is increasing exponentially in the aspect and highest concentration, which is where the organism E. coli can't grow in the center. See, it is 1, 10, 100 and the 1000. But very strange thing has been found in this whole experiment. When this inoculum was poured at the end, this inoculum was poured at the end, at the both end it was poured, that is here and the here. Now the organism start to grow, and this whole practical was of 12 days. Within 1 to 2 days, they acquired the region where no antibiotics was poured. See, this is the region, these two regions. Okay. Now coming to the next slide, see what happens, how the bacteria evolve. See, now they start to grow beyond the no antibiotic zone, and they are acquiring other portion very fastly. Within a 12 days, the whole petri dish was full. Hello. 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 All can hear my sound? Hello. See the slide. We have some technical glitch here. The slide is not uploading. See, one by one I am trying to solve the problem. Here. Slides on. We have some technical problem here right now. Wait for a few minutes. Just I am solving it. See in this slide. Hello. Hello. Wait for a few minutes. The slide is not moving. It is taking quite longer time. Just I am.
Hello. Hello. Jatin, can you hear me? Just wait.
Yes. But slides are not moving right now.
Yes. Please go on. I request to all the participants, Karunakar. Dr. Karunakar, please off your mic. You disturb to all. Put mic off of Dr. Karunakar from your screen. Jatin, you can mute the participant mic from your
Just I
screen.
am trying that due to there is some technical glitch here. Just I am managing that thing. I can turn off, but somehow wait.
Okay, let's start our today's webinar. Sorry for the interruption. There is a huge technical problem, and also the atmosphere of the Navsari is not very good. Very rainy season is today. Heavy rainfall as well as the mild storm. So let us start our today's webinar. I again welcome Dr. Jatin Patel, which will be delivered on webinar. The topic is use of antibiotics in veterinary practice. I again request to all the participants, please off your mic as well as the webcam. It will be very much useful for us to improve our presentation. I request Dr. Jatin.
Yeah, good morning to all again. Just now we'll start our webinar, use on antibiotic in veterinary practices. We were at one slide that how the bacteria is evolving. And again, just I am repeating that this is a one petri dish, and it is not a small petri dish. It is not large size, and the size of this petri dish is around 2 feet to 4 feet. And this, as we are inoculating the bacteria in a small petri dish, same thing they have done here, but somewhat in a different way. Like they have divided the zone of this petri dish in some horizontal lines. And in these lines, they have provided one antibiotic called ciprofloxacin, like at a 0 concentration, 1, 10, 100, and 1000. See, we know that around 10, 100, and 1000 E. coli bacteria can't survive. And same bacteria has been inoculated in a 0 zone. So at the first time they inoculated here and here. And now we'll see how gradually they are growing. See, in this slide, after 2 days, they have acquired the whole portion of 0 concentration. And next one day, what happened? Few bacteria start growing in the 1 microgram concentration. And then again and again, and that's the time 10 concentration. And after completion of the 10 days or 12 days, you can see that the whole plate, there are some organisms which are living in the concentration of 1000 microgram. Now, in a nutshell, we can say that always bacteria is fighting with the antibiotic. Okay, this is one conclusion what we can say that. Now, antibiotic resistance is not new. It existed long before the people used the drug to kill bacteria. That means the bacteria is also a living organism as human beings are there in this world. And we are developing new antibiotics against the bacteria. Like as we are playing even biological game with the use of bacteria, with use of antibiotic with the bacteria. And we always prescribe the antibiotic to fight against the bacteria, and bacteria are gaining the resistance slowly and gradually, but it is somewhat in a very fast pace. Like in the last 20 years, only 6 antibiotic is approved to use in a clinical practice. But in the same time, this bacteria had gained resistance at a very fast pace, which is very fast in comparison to development. Taking all this background, and just I like to say that antibiotics are critically important in veterinary healthcare. And antimicrobial stewardship means the right dose, right bacteria, and the right site of the infection where the drug can go. Means it is important to maintain the clinical efficacy, and we have to use all the antimicrobials in such a way that to reduce the development and the spread of microbial resistance. And it is evidently clear, it is very clear that in today's era, we need to optimize the antibiotic prescribing. Why? Because we want to preserve our current armamentarium. That means whatever the antibiotic we have in our kit. Now, this is the overview of all the antibiotic mechanism where we are using, like cell wall inhibitor, DNA, protein inhibitor in 30S, 50S, there are some cellular membrane dysfunction. This is the whole class of the antibiotics which has been discovered, and these are the antibiotics which are acting on the cell wall and the envelope, like penicillins. These are the few antibiotics like amoxicillin, ampicillin, combination that we use like sulbactam, clavulanic acid, piperacillin. These are on the tip of the tongue. Few cephalosporin like ceftiopur, cefquinone, cefovecin, ceftriaxone. These are the few antibiotics routinely we are using. Now coming to the protein synthesis inhibitor, here there are some antibiotics like amikacin, gentamicin, and in the macrolide like erythromycin, azithromycin. Coming to the next list, that is the nucleic acid inhibitor. Like sulfa drugs, though they are used in the combination with the trimethoprim or methoprim, but today sulfa drugs are lesser prescribed due to the resistance. Now coming to fluoroquinolones, which is widely used in today's era. It's some important drug like enrofloxacin, margofloxacin, levofloxacin. These are used in the veterinary practices. And few drugs like metronidazole, tinidazole, ornidazoles are used. for GIT as well as the uterine infections. Coming to some important aspect of the pharmacology that we need, how we can use, now we can optimize our drug, antimicrobial drug dosage. These are the 4 criteria. Like 1, which is the bacteria and what is the MIC. Second, what is the site of the infection and what the concentration we need at the site of the infection. Third, pharmacokinetic, and fourth is the pharmacodynamic. So, in today's webinar, we'll discuss only 2 points, that is called, that is the pattern of antibacterial activity and the volume of distribution, to satisfy all the 4 parameters of the antimicrobial drug dosage. So, one by one, we'll go through it and we'll have some example in each and individual case. Now, why I had choose this volume of distribution here? The volume of distribution has direct correlation with the half-life and the clearance of the drug. And as we know that half-life means it is the time at which our drug concentration decreases to the 50% in our body. It means in the plasma, what we can say. And the clearance means how much the drug has been cleared in a per unit volume. These are directly correlated. And volume of distribution is directly correlated. It has a positive correlation with the volume. Means we can say that half-life and inversely correlate with the clearance. Now we'll see the patterns of the antibacterial activity. As we have already some veterinarians are knowing about what is the time dependent as well as what is concentration dependent activity. Now coming to the first aspect, that is time dependent killing. What it means? It means that how much time that our antibiotic what we have administered inside that animal remain above the MIC in a particular dosage interval. Okay, this is thing. Means in other way we can say that the extensive amount of time that antibiotic bind to the microorganism. Okay, so the thumb rule here for the time dependent killing is that the drug should remain more than 50% of the dosage interval. Means whatever the time, suppose there is a 12-hour interval of the dosage interval, drug should move above MIC up to more than 6 hours. And the best example in this category is the beta-lactams and the cephalosporins. Now, see this 2 graph. This is just comparison to explain the time-dependent killing. Drug A and drug B. If the drug A remains above the 50%, means we can see the graph. This is the particular MIC of an organism, and the time what we see, the time span is more than 50% of the whole 1 dose interval. The drug B is having 30% only, while the drug A has 50%. So, drug A is a better drug which should be used to optimize our therapy. Coming to the next section, that is called the concentration dependent killing. Here, the concentration of an antibiotic is very much important. Here, the rate and extent of the killing increases as the peak of the concentration increases. That means the higher the concentration, in a rough way we can say that if the antibiotic concentration then more than 4 to 5 times, its the rate and extent of the killing increases. There is one additional advantage with this concentration dependent antibiotic like aminoglycosides and the quinolones. They have post-antibiotic effect. See, this graph shows the comparison of the Cmax, that is peak of the drug that is given to the animals. That is the ciprofloxacin, enrofloxacin, difloxacin and marbofloxacin. We can see the marbofloxacin has acquired the highest Cmax here. So when which antibiotic will have the higher rate of killing, that is marbofloxacin. And one thing that you have to note that concentration is quite low in comparison of the enrofloxacin. Now we'll discuss something about the additional advantage of the to this concentration dependent antibiotic. There is post-antibiotic effect. This refers that what it refers the persistent suppression of bacterial growth following exposure to an antimicrobial. That means, in a very crude way, we can say that the time taken by the organisms to recover back after the exposure of the antibiotic. Here we can see that this is the portion where we can see PAE. It is also sometimes called sub-MIC portion. And we know that in vivo condition, and fluoroquinolones and aminoglycosides possess the PAE, and this gives the advantage of dosing of the drug for having interval of 24 hours. Now, this prolonged PAEs for the gram-negative bacilli is obtained due to they have the mechanism to inhibit the protein synthesis and nucleic acid synthesis, as well as the aminoglycoside, fluoroquinolone, tetracycline, macrolide, chromophenol, and the rifampicin. These all drugs are having the same mechanism. Now, when we compare with the beta-lactam and cephalosporins, they possess very short PAE and no PAE. Okay, means there is only one exception, that is carbapenem drug. Now into it that how we can evaluate this concentration dependent antibiotics and the time dependent antibiotics. See, for the time dependent, we have one parameter called T greater than MIC. For the concentration dependent, we have two parameters, that is Cmax MIC and the AUC MIC. Now just we are summarizing the whole thing for the pattern of antibacterial activity. That means type 1, type 2 and type 3. The type 1s are the concentration dependent with additional advantage of prolonged persistent effect. And here we know that fluoroquinolones, aminoglycosides are the group of the drugs which are included in this and we are using in our clinical practice. What should be the goal of therapy? Here, maximum tolerable dose, maximum concentration, therapeutic dose should be used. Here, dose is high and frequency is low. Here, the parameter what we use, peak is P by MIC. That means your peak should be 10 to 12 times greater to have a optimized dose. Second, type 2 is time dependent killing. They have the minimal persistent effect. Here, two important groups, cephalosporins and the penicillins we are using. The goal of the therapy will be maximize the duration of exposure. They does not give the concentration. The duration of the exposure should be widened. So, whenever you are using the cephalosporin and penicillin, except for one or two, you should lengthen the duration of exposure by giving the drugs 2 times a day. Here, the parameter is T greater than MIC. For the gram positive, it should be greater than 40, and for the gram negative, it should be 70 to 80. There is third type, time-dependent killing and moderate to prolonged persistence, that is azithromycin, clindamycin, tetracyclines. Here, the maximized amount of the drug should be used. The parameter like 24 hours MIC is used. Here, the important guideline is that for the gram positive, 35 to 40, and gram negative, 100 to 125 should be used. See, this AUC MIC is also applied for the fluoroquinolones also. For the fluoroquinolones, we use two parameters, peak is to MIC and the AUC MIC. Now, one important thing that for the time-dependent killing, increasing of the concentration of the drug in excess of the MIC of the pathogen does not increase the clinical rate. You have to keep in mind, concentration will not work for the time-dependent killing for the beta-lactams as well as the cephalosporin. We'll see a few examples to get a better understanding about what is T greater than MIC. This is the one graph showing the survival in the animal models against the infection of Streptococcus pneumoniae. See, when the time above the MIC was around 20%, mortality was high. But when as time above the MIC increases, see up to 60 to 80, it comes up to 0%. Means if you give the optimum time above the MIC, then the clinical cure rate will increase. Coming to next, see this is same thing but in a different form. Your time over the MIC, if it's reached above the 60, see the clinical cure rate increases. Now, these rules is not applied in slow growing bacteria. Okay, here the slow growing bacteria are generally infect over the region like endocardium, osteum tissue, like they cause the endocarditis and osteomyelitis. Here it is required, what we require, the longer duration of effective serum concentration of agent is required. Means the dosage regimen should be applied for longer time and the serum concentration should remain above the MIC for the longer time. Coming to the AUC MIC, here we have used ciprofloxacin. 64 patients has been cured. We can see when the AUC MIC was above 125, the microbiological as well as the clinical cure rate increases. This is a second example. Here see, as the AUC MIC is above the 100, the mortality rate is decreasing. This is one example how we can look into this graph and we can optimize our therapy. All these graphs are available through research article as well as in the internet Google source. See, here if any bacterium is having MIC of 1 microgram and we are using the orbifloxacin, see what is the Cmax MIC? It is 2.4 and AUC MIC is 14.3. This is not sufficient to kill the bacterium. Okay, see if any other bacteria which is having 0.5 MIC, still this antibiotic is having no good option because Cmax MIC should be above the 10 and AUC MIC should be minimum above the 100. Then if we take 0.5, 0.25, again it reached to 10, Cmax MIC reached to 10, AUC MIC is still 57. But the bacteria which is susceptible to 0.12, we can see these parameters are good. So orbifloxacin should be used for the bacteria which are susceptible to 0.12 microgram per ml because they have Cmax MIC above the 10 to 12 and AUC MIC is above the 100. So in this way we can optimize our therapy. Coming to the next parameter, that is volume of distribution. Volume of distribution is a just theoretical volume. In the next slide, I will explain what is this volume, body volume, and how we can correlate with the volume of distribution. But just we'll look into it. It is the total amount of administered drug at the same concentration that is observed in the blood plasma. Here it represents, this is the symbol of the volume of distribution. It represents the distribution inside the body rather than the plasma, even though we are measuring the concentration in the plasma. In a very simple way, the higher the VD, greater amount of tissue distribution. Smaller the VD means the drug is staying inside the plasma. It is not distributed in other part of the body. See, in the veterinary practices, we have the different type of the animals like dog, cat, cattle, buffalo, horse, and any other species. But one thing is common, that total body water percent remain common here. That is 60%, whether it is cat, yeah, it is dog. Now, keeping this view that it is 60% of body weight, we take a volume of around 40 liters. And we can see that from this total body water, intracellular fluid comprise about 40%. From this 60, 40% is here and 20% is the extracellular fluid. Means if a drug which is entering in the intracellular fluid will have the high volume of distribution because it's able to acquire the larger volume inside the body. If it is going in the extracellular fluid like interstitial fluid, Yeah, in the plasma volume, it's about 50%, 15 liters, that is 20%. That means it has very medium or low volume of distribution. Means they comprise their area in the extracellular fluid only. So from this, we can say that the drugs which have around VD of 0.1, yeah, the volume of distribution is 5 liters. They have low volume of distribution. They generally remains in the vascular compartment blood and its surrounding tissue, very highly perfused tissue only. Coming to the 0.3 medium VD drugs, they can acquire the extracellular compartment up to 20 liters, 15 to the 20 liters. Okay, and they are small hydrophilic molecules that do not bind to the plasma protein. And last category is a high VD, that is greater than 40, means it's acquired most of the body water, and the ratio is 0.6, means they distribute throughout the tissue, and they are very small lipophilic molecule that bind strongly to the extravascular protein. From the volume of distribution, we can classify two types of the antibiotics. One is the hydrophilic and second is the lipophilic. Now the hydrophilic are more polar as well, but they are highly ionizable and exhibit high plasma protein. So due to this, you will find the smaller VD, and as they are water soluble, they are predominantly excreted through the kidney. Okay, they comprise the beta-lactam and aminoglycoside category. Coming to the lipophilics, they are highly lipid soluble drugs, means non-polar drugs, low rate of ionization, and the low protein binding capability. Ultimately, they have the larger volume of distribution. They are cleared by the hepatic metabolism, and they have very good intracellular penetration. That is fluoroquinones and the macrolides. Now, how to utilize this volume of distribution and what the change should be produced in dosage regimen according to the infection site. See, if the infection site is blood, what is the alteration in these parameters? What happens? The VDs expand. But at the same time, clearance is also expand. Means whatever drugs we are giving in the blood, it is cleared to the kidney. Now what happens? What practical approach should be there? Here, loading dose means a high concentration dose should be given, and the frequency of dosing should be increased, which will maintain your antibiotic concentration above the MIC to optimize your therapy. Suppose if it is target of the lung, see, when there is infection, the permeability of the alveoli changes. What it happens, that does not allow to enter the drug inside this. That means you have to increase the dose. You have to increase the dose, which will bypass this, and means the more drug enters inside the affected tissue. Same thing like for the bone and the CNS. Same, increase the dose and duration of therapy should be applied for the bone. Bones are one of the such a tissue that antibiotics go at a very least concentration. Okay, so here one again, duration of therapy is very long for the bones. Same thing applies for the skin also. Duration of the therapy is very long because skin tissue is having very less blood supply. Coming to the CNS, same, impaired permeability because they have one blood-brain barriers, and the maximum dose of the therapeutic regimen should be utilized. For the soft tissue, only the case that if animal is obese, and there you have to increase the dose. In this way, if according to infection site, some pharmacokinetic concentrations are changes, majorly the VDs changes, at that time you have to change your dosage regimen. Now, especially talking about the meningitis. The meningitis, we have the blood-brain barrier here, and degree of the lipophilicity will help to enter inside this meningitis. But in the stage of infection, the blood-brain barrier is somewhat compromised. At that time, few hydrophilic molecules can enter inside, but they are of no use without concentration. What it requires to inhibit to kill the bacterium, means to kill the bacterium, it is not sufficient. Yes, there are some CFS is the plasma ratio that the fluoroquinone, which is highly lipid soluble, they can acquire good concentration in the meninges, but the beta-lactam and aminoglycosides, they acquire very less concentration in the meningitis. Now we'll see a few examples of routinely used antibiotic in the veterinary practices. That is volume of distribution. Here we can see this is one of the cephalaxin. See, when we go through the various data from the various animal, that is, it is around 0.2 to 0.4. That means this antibiotics remains in the extracellular fluid. Same thing is seen for the cefepime, the range between 3 to 2 and few exception with the 0.4 in some species. For the cefquinone, which is most widely used, means today's drug we are using in the field for the management of the mastitis. Here, volume of distribution is around 2. Same thing, they resides in the extravascular compartment only. Coming to the next, ceftriaxones, widely used by the veterinarians. Same thing, 0.2 to 0.3, with a few exceptions with the cat and the mice. And we can see that they resides in the extravascular compartment because the value is around 0.2 to 0.3. One again important safety occur. Across the species, you will find average is around 0.2 to 0.3. Coming to the next, moxifloxacin and marbofloxacin, they are from the fluoroquinone groups. See, VD is more than 1. That means they enters inside the cell, they acquire the volume of the intracellular compartment. Same thing is found in the endofloxacin and the difloxacin. Now, when the VD can be changed, the disease states where kidney as well as the liver is affected, here VD will increase because there is decrease in the synthesis of the plasma protein. Plasma protein will be less, this drug will not bind to the plasma protein. While in the dehydration, due to decrease in the total body water, the volume will decrease. In these two conditions, you have to take care to optimize the dosage regimen. So we have taken some knowledge about both the thing, volume of distribution as well as the pattern of antibacterial pattern of the what we can say time dependent as well as the concentration dependent. Now we'll see few cases. That is, first I am taking the mastitis, then later on the skin disease, urine disease, as well as the endometritis infection. So we'll start to apply. Now in the mastitis, for the clinical mastitis, typically or acute mastitis, antibiotic treatment is one of the main features for its control. And this therapeutic effects mainly depends on the disease severity, which type of drug we use, and how we prohibit the predisposing cause. Before going into detail about this antibiotic, that means these are some few common microorganisms. There is Streptococcus agalacti, Streptococcus big agalacti, Staphylococcus aureus, other Staphylococcus species, all form on the mycoplasma. When we see which are the organisms resides in the milk and milk duct, that is, these are the two and other Staphylococcus. These are three type of the organism like Streptococcus agalexi, this agalexi, and other than the Staphylococcus aureus. Okay, and which are acquiring the parenchyma, udder tissue, that is Streptococcus and the Staphylococcus aureus. But the Streptococcal species are acquiring less portion of parenchyma, but mostly they are residing in the milk and milk duct. And the last two types, coliform and coliform mycoplasma, they resides in the cow. Cow means they distributed throughout the organism through the udder. So, on the basis of these pharmacological compartments, I like to say that the organisms which are residing in this milk and milk duct, intramammary is more preferable, while in the parenchyma, parental route is preferable for the cow also. In parenchyma, two types, means intramammary as well as the parental, but in the cow, means whole body, the parental therapy is more effective. Now, looking to some clinical side, that is the acute or severe mastitis, the animal shows some clinical signs like fever, in addition the abnormal milk, and with the udder swelling. Here, if we give the intramammary administration, often it fails due to poor or uneven distribution of the drug and due to blockade by some of the products that is produced with the inflammatory conditions. Here the only success can be achieved. Success can be achieved while the parenteral therapy only. And if possible, you have to strip the milk to decrease the bacterial load from the severely inflamed udder. So, in this table, looking to this severe, what we can say, mastitis, here I had classified the organism on the basis of milk to plasma drug. And we'll correlate all this drug with the VD, volume of distribution. See, when we see the chemistry of these drugs like penicillin and cephalosporins, which are categorized as the weak organic acid and they are water soluble drug. Looking to those category, they have the less volume of distribution, and we can see the milk to plasma drug ratio is around 1 and the 0.2. Whatever drug we have given inside the plasma, only 1 to 0.2%, means 10 to 20% comes inside the milk. The second category, where the volume of distribution is very high, like the fluoroquinolones and the oxytetracycline, they are the lipid soluble drugs and they are the amphoterics. See, about 60% to 100% drugs comes inside the milk. Third category, that is organic basis, which can be water soluble and the lipid soluble. In the water soluble category, the aminoglycosides are major category. They, as the organic basis enters inside the milk, around more than 100%, we can say that. Whatever we have dosed, that enters inside mostly up to equivalent to the plasma concentration, they enters inside the milk. Same thing we can see for the macrolide and the lincosamide. In this table, we can see, had summarized, means we can see many antibiotics what we are using for the mastitis, but only the organic base which are lipid soluble as well as which are water soluble can enter inside the milk. Now, why only the organic basis enters inside the milk? So we'll see in this discussion that the serum pH is 7.4, the milk pH is 6.6 to 6.8. Whenever we are giving the organic base like the aminoglycosides, when the milk pH is around 6.6 to 6.8, they are around up to 7. Then normally what happens, this all the organic base are ionized, they enters inside the milk and they get ionized. Means ion trapping mechanism take place in the milk. That means this drug achieve very high concentration in the milk. But in the mastitis milk, the pH is changed. It is above the 7. Means it moves toward the alkaline side. Then what happens? As the pH increases in the mastitis milk, this organic base can be trapped inside the milk. Unless and until they are having the high lipid solubility. That means aminoglycoside drug like gentamicin, which is totally water soluble, it will not come inside the milk. That means it is no use, means there is, what we say, gentamicin has no role for the treatment of the mastitis in the abnormal pH, means in the mastitis milk. But the compound like the erythromycin, which has very good lipid solubility, they can gain very good concentration inside the milk. But when for the organic acid, if the milk pH goes beyond 7.4, which is above the serum, then the concentration of organic acid and means it's entrapped inside milk, means penetration is increase inside the milk, and it will go above the 1. That means more than, it is equivalent to the plasma concentration that is achieved. But milk pH need to be reached more than 7.4, and it is quite tougher in the clinical aspect. So, what are the drugs which can use for the coliform, which have activity against the coliform bacteria? Okay, see, there are few drugs I had enlisted like OTCLA and the sulfa with the ormetropin. These two drugs had been used for longer time, but due to acquirance of the, what we can say, the resistance, these drugs are lesser used in field practices. But today, only two groups like the cephalosporins and the beta-lactams and the fluoroquinones are used. Some few drugs like ceftiofur, ceftriaxone tazobactam, cefaperazone tazobactam, cefquinone, amoxicillin, clavulanic, androfloxacin, and gentamicin, some are used. But whatever discussion we have done, gentamicin should not be used in the where the pH of the milk is quite above the neutral pH, because this gentamicin will not enter inside the milk. Even, and second thing, gentamicin is having very less lipid solubility, is more water soluble, so it will not distribute in the other tissue at a required concentration. So we'll discard the gentamicin to use for the coliform mastitis, even though the gentamicin has very good in vitro susceptibility with this coliform bacteria. Again, just I had discussed here, like when we administered systematically, sulfa, penicillin, aminoglycoside, and early generation cephalosporin do not readily penetrate the mammary gland tissue. Only macrolides, trimethoprim, tetracycline, later generation of the cephalosporins and the fluoroquinones enters the mammary gland. Coming to the next category, mild to moderate mastitis. Here, the features of clinical manifestations are abnormal milk with and without the mammary swelling. Here, the preferred route of administration is the intramammary, because the most of the bacteria are residing in the duct, that is Streptococcus species and few non-Staphylococcus aureus species. Now, coming to the benefits of intramammary administration, in particular this case, is that the antibiotics reach in very high concentration in the milk, and the loss of the antibiotic is less due to drug absorption and the transfer process from the biological membrane. There is one disadvantage here due to uneven distribution, due to change in the inflammation of the alveoli, means other alveoli, then when you can say that the distribution pattern will be changed, but it depends on the pattern of the inflammation in the udder. Second thing is that whatever the entering mammary formulations are prepared by the pharmaceutical companies, they are made in such a way that they are released very quickly inside the udder, and the main objective is that they eradicate the infection of glandular tissue and minimize the withdrawal time. Any preparation that is made for the dry period administration should not be given in the lactating animal by mistake also. Coming to the group of the drugs which can be given for the intramammary administration, that is, these are only few, and we can see this all the drugs are exhibiting the time dependent activity only. So one thing is that the TH2 MIC should be kept optimum. That means whenever you are giving this drug, kindly give 2 times a day. That is, up to your dosage interval should be 12 hours. Many a time, use of hormone like oxytocin will help you to get the letdown of the milk, and this letdown of milk will decrease the medium for the growth of bacteria in the duct. After remove all the milk and give this antibiotics. Now we'll see some antibiogram of the patterns. Means, and this is for some bacterial isolates. This study is of Gujarat only, and this is done in the Sabarkantha district in collaboration with NVDB and Anand Agriculture University. Here we can see that they had acquired, means they have isolated few isolates of the Streptococcus agalexi, this agalexi, E. coli, Staphylococcus aureus, and Klebsiella. See, these are the few antibiotics they had tested in vitro, and some important thing we have observed that the ceftriaxone tazobactam, which is widely used today in the field condition by the what we can say by the veterinarians. See, most of the isolates are susceptible to this. That is, 97.30% are susceptible. Even though, see, this is a gentamicin, I had already discussed that gentamicin will show very good sensitivity in vitro, but the pharmacokinetics does not favor to use in the mastitis. Second is the tetracycline, which has 82%. Cefoperazone sublactam has 79%. These formulations also we are using in the field. Though the enrofloxacin is giving very less susceptibility, but when we use in the field condition along these things, if you optimize the therapy, then I surely the enrofloxacin will give good activity against the most of this pathogen. Ampicillin, cloxacillin has acquired some resistance, and the susceptibility is only 4% in this area. Coming to this graph, means what this graph says that this is the ceftriaxone plasma versus time graph. This is very simple. The drug has been given to the animal through intramuscular dose, and we have seen through intramuscular route, the peak has been acquired at in a very small time, up to within the 30 minutes, and it lasts up to the 12 hours. That means whenever we are using the ceftriaxone, this drug should be repeated at least 12 hours to get a very good clinical cure. And to keep, we can see that the MIC microgram per ml is around 0.5. That means it can cover most of the pathogen of the mastitis. Only I am not sure that this antibiotic is good for the staphylococcus, because the staphylococcus is residing inside the parenchyma of the udder, and we require the higher concentration in the plasma. That means you have to dose at every 6 hours to 8 hours to acquire this concentration in the parenchyma of the udder. This is the second study. Here the ceftriaxone has been given by 20 mg per kg intramuscular. See, these are the milk concentrations. These are the milk concentration after first, third, fifth, seventh, and the ninth. See, at the 4 hours, the concentration is 5.26. At the 4 hours. Same thing it is exhibited in our previous slide. See, okay, same thing. And the third dose, fifth dose, seventh dose, and the ninth dose. Here, the pattern we have to see that as we have administered the drug in a regular fashion, the concentration of antibiotics appear more after the last dose. Coming to the next study, this is somewhat diverse thing. Here they have acquired some isolates from the clinical mastitis, and they have seen that MIC90 means the MIC taken from all the isolates, and we are summarizing it. These are the common bacteria which is isolated from the milk. For the aureus is 1, Staphylococcus other species 0.5, Streptococcus agalacti in this egg is 0.25 and 0.25, Uveris is 0.5 and E. coli is 2. See, looking to this all the MIC90, then how we should dose our animal, how we should formulate our doses regimen. If I am taking the E. coli MIC, it is around 2. Around 2. So this is the amoxicillin sulbactam combination. This scientist had used to treat this animal at 12 hours. If you use this 12 hours, then the drug remains above the MIC more than 50%. That means using this older antibiotics, we can get very good clinical cure because we are keeping our time above the MIC more than 50%. It is about 70%, yeah, 80%. See, at the both time they have dosed, the plasma concentration has increased. Again, after 24, they are given, and then the concentration decreased. But within this time frame, the drug was above the MIC more than 50% of the dosage interval. Coming to the subclinical mastitis, this is the category where large form of the means when we say percentage find, it has spread widely in our India and in the dairy cattle. But the subclinical mastitis, unless and until it does not convert into the clinical, mild mastitis, the antibiotic should not be used, but it should be managed with other managemental things like using of sodium citrate. That means maintaining the acidic pH of the milk throughout the lactation period. Use of sodium citrates has been done by the veterinaries and the cooperatives in some districts, and they have found very good results in this thing. This is all about the mastitis. Only one thing I have to get. If you are using the cephalosporin beta-lactam, use twice a day to maintain T raised to MIC above the 50%. And if you are using the enrofloxacin, some levofloxacin, marbofloxacin, please dose the animal at a particular, exactly at the 24 hours. If you can't get the result, then you have to repeat up to 18 hours to keep the concentration higher. Now coming to the cases of metritis, endometritis, which is widely seen after the mastitis, means when we categorize the clinical case from the veterinarian perspective, the gynecological problems are at higher percentage. Means it acquires more than 50% in their clinical practice. When we define the metritis and endometritis on the basis of the pathological aspect, means metritis is a severe inflammation of all layer of the uterus, and the endometritis is the inflammation of the functional lining of the uterus. Before going in detail, I like to go to this metagenomic study, which explains some few highlights of these physiological constraints and how the bacteria resides inside the uterus. This study was done in the Anand Agriculture University. They have taken the 50 vaginal aspirate from the 35 different buffaloes and from different reproductive status. Okay, and from that they have done the metagenomic study, and they found that there is quite diverse amount of the microbial species has been found out. That means they found that 33 phyla, 779 genera, and 2,859 species in their study. Means what it shows that there are many bacteria and other species are residing in that environment. Now, what is the importance of this bacteria? See, from this study, I came to know that if animal is under the progesterone effect, that is, animal is pregnant, then only few bacteria are present. But if animal is acyclic and endometric, then we can see very large number of bacteria acquires the tissue. Means there is dysbiosis between the, disbalance between the bacterial population. Now, looking to this, all the bacteria which are present in the pregnancy and in the endometritic patient, see, same thing has been seen in the acute metritis and the clinical metritis. That this summary I have taken from one of the article. This shows that in the acute metritis, E. coli is the most prominent pathogen, and these two other are Archaeobacterium, Pyogen, and Streptococcus. While in the clinical and subclinical endometritis, Fusobacterium and other gram-negative anaerobic bacteria like bacterials are the major culprits. See, now how we can use this information to optimize our therapy. In this way, for the acute metritis, we have to give two types of therapy at a time. One is the injectable drugs, which is very good, which can acquire very high concentration inside the uterus, in the uterine tissue. Second is the intrauterine, which is the lumen condition, where debris are present and all of the bloods and tissue debris or placental debris may present. Here, drugs you should use some drugs which has good penetration inside the lumen and the endometrium, but at the same time there should be no irritation. Second thing is no negative impact on the uterine immune cells. But in the clinical practice, only intrauterine therapy is sufficient. Okay, looking to these things, when we are using drug for the intrauterine, so clinical or subclinical endometritis, always use like metronidazole or tendinidazole group to treat the gram-negative aerobes and the Fusobacterium necrophorum, along with some beta-lactam antibiotics, which will cover most of the bacteria inside the uterus. When you are using the acute metritis, the drugs like enrofloxacin should be used, and some drug like ceftiofur, ceftriaxone should be given parenterally, which will acquire. But in intrauterine, if you are using same therapy what we are using should be used for the acute metritis. But I like to say that when you are using the antibiotic for the intrauterine, same thing that should be used for the injectable, which will cover whole mass of our body. Now coming to some factors which are affecting the selection of antibiotic for the treatment of the metritis and the endometritis. Here, one important thing, again just I am repeating it here, you have to select the antibiotic which have activity on the E. coli. This is the most prominent bacteria which is causing these infections. Second is Archaeobacterium pyogens. Thirds are the gram-negative anaerobes, that is Fusobacterium and the bacteroids. Second, when we talk about the tetracycline, which was used widely for the treatment, but the tetracycline has very less activity in the reduced oxygen availability. That means an anaerobic condition, these drugs are having less activity, and moreover, we are using this drug from the long time, and it has increased means this resistance has been increased markedly. Coming to the second category, there is aminoglycosides. Few of the veterinarians are using this gentamicin for intrauterine therapy. But when we look the chemistry of gentamicin, they have no spectrum on the anaerobic bacteria. They are totally resistant to they are inherently resistant to the gram-negative anaerobes like bacteroids and other. Okay, And second thing, they utilize the oxygen for their activity. But in anaerobic environment, their activities drastically reduce because there is no oxygen availability. Coming to the penicillins, these penicillins have very good activity against the Archaeobacterium pyogenes. Second things, these penicillins are susceptible to the penicillinase enzyme that are produced by the bacteria, and so always use the amoxicillin sublactam combination to get the better cure result. Coming to the best approach for the intrauterine therapy for the infection like mastitis and the endometritis. First of all, for the intrauterine, complete siphon all the uterine content. Try to make whole uterine environment more aerobic. Okay, then you will get the good activity. But it is very difficult to siphon all the content in the field conditions. So whenever you are using your drugs for the endometritis, kindly use this drug, metronidazole or tinidazole combination, which will acquire all anaerobic bacteria spectrum. Second, use the gram-negative spectrum like enrofloxacin, levofloxacin, some cephalosporin and cephalexin-like drug, which will cover the E. coli, which is the most common culprit for the endometritis. Second, if you are using the drugs for the metritis, that is purpureal metritis, in the purpureal, we should use the drug for the parenteral administration. That is, here we can use the drugs which can acquire more concentration inside the uterus lumen, that is enrofloxacin, oxytetracycline, and the ceftriaxone, because all these drugs penetrate more in the extracellular matrix. Now, the days has come to refine our therapy and to use some additional drugs like prostaglandin or the other drug like estrogen analog, ergot alkaloid for our therapy. How they will be helpful? Now the science says that metritis-like condition impairs the luteal activity transiently. Now this luteal activity, how we can eliminate this luteal activity? Use of the prostaglandins, we know that it will clear the corpus luteum. When the corpus luteum is removed, the progesterone effect is removed. Ultimately, there is elimination of immunosuppressive effect of the progesterone. Ultimately, it improves the contractibility and most of the all debris moves outside the uterus naturally. Moreover, there is direct stimulation of the immune cells of the endometrium. Some studies I had gone through, here some scientists had used the prostaglandins alone for the endometritis. But what happens? They found the relapse of endometritis in next estrous cycle. Here what mechanism works? That means you will get clinical improvement in that cycle. But the bacteria which reside inside the endometrial crypts are still living, and when the immune functions of endometrium goes down, then this bacteria start replicating. At that time, you will find relapse of endometritis. In such condition where there is luteal phase activity, if you find in your clinical practice, use the prostaglandin in the combination of anti-infective therapy, what we have discussed in above slides, which will eliminate the existing bacterial infection and which will prevent the reoccurrence of the conditions. And in the subsequent estrous cycle, you can do the artificial insemination with a better estrous sign. Now, coming to the purpureal metritis, which is this type of metritis commonly occurring within the 10 days of the parturition, and it is characterized with the very good fluid content, viscous, foul-smelling, purulent discharge from the uteri. In such condition, two drugs we are using. We are using in the clinical practice. First is the methyl ergometrin, this is ergot alkaloids, and second is oxytocin. But if you are using oxytocin, kindly be sure that your uterus is estrogen prime. If uterus is the estrogen prime, then only the oxytocin will work at a 100% capacity. Okay, and this methyl ergometrin and oxytocin will help you to evacuate most of the content before the antibiotic therapy. Okay, whenever you are using any antibiotic, again I am to say that don't use concentration dependent for the intrauterine preparation. Use some drugs which are having time dependent activity, and kindly ensure that this T raised to MIC has been optimized. Now, coming to the next portion, that is urinary tract infection. These are the common infection we are finding in dogs and the cat. Only I will talk about the uncomplicated urinary.
Yes, antibiotic.
Yeah. Hello.
Hello. Okay. Now we'll discuss the drugs. Drugs which can be used for the urinary tract infection. There were some, again, the technical glitch. Within a 30 seconds, I will join with this thing.
Okay, now we can continue this session. Again, looking to the important pathogen, what we can target for the urinary tract infection is the E. coli. So we'll optimize our therapy mostly blindly for targeting the pathogen. That is, we have to look into pharmacokinetic characteristics and the spectrum of antibiotic activity. And looking to the E. coli, what drugs we should be used for the urinary tract infection. And here, looking at pharmacokinetics, we have to select such drugs which are primarily excreted in the urine. This is the most important criteria. Primarily excreted in the urine and achieve the high concentration inside the urine. And with the same time, the animal should have the normal kidney functions. If the animal is having some kidney disease, these fundamental rules are not applied. Because number one, in the kidney disease condition, your urine output is decreased, means your drug will be not excreted in the urine for the treatment. Means glomerular filtration is decreased due to the kidney problem. This whole picture show that few antibiotics are available with us which can acquire very good urine drug concentration. You see, amoxicillin 202, amoxicillin clavulinate 201, chloramphenicol 124, levofloxacin 490, subsixalzole of 1466, coming to amikacin 340. But amikacin should not be used for the urinary tract infection because it is nephrotoxic. Now, there are some conditions like if it is UTI infections, if you have pyelonephritis or prostatitis. There are three important conditions for the treatment in the urinary tract. So, there are few antibiotics already we have discussed, but these are the dosage guideline, how it can be used. These two already we have discussed, that's amoxicillin, amoxicillin clavulanic acid. Both these drugs are not prescribed for the pyelonephritis and the prostatitis. One cefovecin drug is available as a subcut injection, but this drug can retain, means it is slowly released inside the body up to 14 days, around to 14 days. Mid dosage interval is 7 days. But as the minimum ADT concentration, what we require is it not acquired by cefovecin for longer time. So it is not worth to use this antibiotic in this condition. One human drug that is called cefpodoxime proxetal. Many trial has been done in the dog. This drug can be given per oral, and this is only cephalosporin, which can be given per oral every 24 hours. Every 24 hours at a dose of 10 and 20 milligram per kg body weight. This drug has very low MIC against the E. coli. Now coming to the next list, that is enterofloxacin, levofloxacin and marbofloxacin. All these drugs are very good for the pyelonephritis as well as the prostatitis because volume of distribution of these drugs are very high. These are lipid soluble drugs, except this levofloxacin, when we compare with the enterofloxacin, it is less lipid soluble drug. So we can use levofloxacin also, and it can acquire good concentration in prostatitis, but enterofloxacin can acquire good prostate concentration at the time of the treatment. Coming to the pyelonephritis condition, here we have to treat the kidney parenchyma, not the flow of the urine. So, and in this also, Enterobacteriaceae families are the most culprit, and fluoroquinolone is the reasonable first choice because most of the enterofloxacin are excreted through the kidney and they are widely distributed in the kidney also. Coming to the prostatitis, this region, prostatitis is a one complicated cases. Once the animal catches the prostatitis, then the treatment duration increase from 1 week to 2 to 3 weeks. But one thing you have to keep in the mind while treatment of prostatitis, which is many times found with the uncomplicated UTI. Here what happens, there is one barrier like the blood-brain barrier. Here is the prostatitis blood barrier. In the inflammatory condition, this barrier is compromised. Compromise means this barrier, when it is not compromised, it does not allow to enter the water-soluble antibiotics. But when it is compromised, the integrity of this barrier is disturbed due to inflammation. The water-soluble antibiotics enter. That is, penicillin and the beta-lactam can enter. Then they can resolve some prostatic condition. And inflammation resides, means bacterial load decreases, and we can see the improvement in the clinical signs in the animals from 1 to 2 weeks. But after the restoration of this blood-prostate barrier, water-soluble and soluble antibiotics can't enter inside this prostate gland. At that time, you have to prescribe the drugs which has very great volume of distribution, like the enrofloxacin as well as the enrofloxacin and other congenital like not ciprofloxacin, levofloxacins and the moxifloxacin or marbofloxacin. In this context, again I like to put one point that ciprofloxacin is metabolite of the enrofloxacin, but it should not be used in the prostatic condition because it has unpredictable bioavailability in the dog by oral route. Second, it is more soluble drug than the enrofloxacin, and the concentration what is required to kill the bacteria inside the prostate gland is not acquired at a good extent in comparison to the enrofloxacin. One another compound like phosphomycin. That is, this is one we can say this is new option, but veterinary data are lacking. But one important thing, if you want to use this drug, it should be dosed at 8 hours, and it is somewhat impractical for the veterinarian, and it has very good gram-negative spectrum, and it can be used for the some resistant gram-negative infection. Chloramphenicol is one of the other option for using in this condition, and you have to keep in the mind it acquires only 60% of the plasma concentration inside the prostate gland in the dog. So it is doubtful to reach in the therapeutic level. Tetracyclines have no use. Even the monocycline and doxycycline does not reach more than 20% of the plasma concentration inside the prostate, so they are not recommended. Now coming to the macrolides. Macrolides are organic based. They are lipid soluble compound, but they don't have any activity against the enterobacteriaceae, so they should not be used at that time. Coming to the last category, skin infection. Here, the most of the infection that is caused in the skin, it is due to the staphylococcus, and it is comprised by the pseudo-intermediates or intermediates group. These are the one and the same. But at the same time, you have to keep that skin is the largest organ of our body, and blood supply is comparatively poor. And same thing I had discussed at the time of the bleeding. What is the site of the infection? If the site of this infection is skin, at that time, duration of the therapy increases. At a very small duration, you will not get clinical cure. But if you improve your duration of treatment with a better optimization of the therapy, with the use of the antibiotic, then you can get good clinical cure. Most of the canine pyoderma cases are secondary to other pathologies, and they can be addressed to obtain the cleaner clinical cure. And with the to get some means using the topical antiseptic treatment will hasten the clearing the infection. There are two types of pyoderma: superficial pyoderma and deep pyoderma. Superficial pyoderma treated exclusively with the topical therapy. Here, with the topical antiseptics like chlorhexidine is only sufficient for treating the superficial pyoderma. If you give your antibiotics parenterally, then also they will reach a concentration in the skin at very less rate. But instead of that, you should use some antibiotic preparation on the superficial application. In the deep pyoderma, here you have to use the parenteral therapy for a very long duration. Here, two things you have to keep: safety of antibiotics and the concentration that should be reached in the skin, in the deep tissue. Okay. And along with this deep pyoderma, you should use few bathing like important component which will help to remove their adherent crust, sticky exudates, and promoting the drainage as well as the drying, which will means local application will helpful to clear the superficial infection. In this treatment, skin treatment, then this is the line: first line, second line, and third line antibiotic. In the first line drug like cefadroxil, cefaclexin, amoxicillin, clavulin, clindamycin, linomycin should be used. Sometimes when the medication is difficult, your patient compliance is very poor. At that time, cefodoxime and cefosavin can be used. But in the normal condition, this drug should be used along with some topical application, which will cover up most of the pathogens. Second line drug, cefovecin, cefodoxime, difloxacin, enrofloxacin, marbofloxacin, orbifloxacin, and the pardofloxacin. These are a few drugs, but from my context, this should not be used at the first instance. Use the beta-lactams, antibiotics, cephalosporin to treat the skin infection, and if it is not cured, then only you should go this. Third line antibiotic should not be used at all unless and until some clinical means laboratory confirmation by the multi-drug resistance organism. Here this is ceftazidime. This is the drug which is very good, which is still it is kept in the third line, which is very good drug for the Pseudomonas aeruginosa treatment. When I had gone through the various literature online, and most of the veterinary dermatological literature found to use 2% to 4% chlorhexidine formulations, whether as a shampoo, whether after in the conditioner, mops or anything, but they are using 2 to 4% chlorhexidine to cover, because the chlorhexidine has this coverage: Staphylococcus pseudointermedius, Pseudomonas aeruginosa, and the Malassezia species. Again, I like to discuss this point: duration of treatment. When you are treating the skin, bone, your some endocardium, where the organism is residing in such a place where our blood supply is poor, at that time the line of treatment, the duration of treatment should be lengthened with optimized dose, so drug side effect is not observed in the animal. Most of the time what happens, poor patient compliance and adherence to the treatment is likely to cause the failure of the therapy. This one PDF I had found that we can see this is superficial pyoderma. Here they have used only 3 to 4% chlorhexidine shampoo in the 10 dog, and most of them has cured within the 4 weeks. Now coming to some antibiogram pattern of Staphylococcus species, particularly skin infection. Here we can see the resistant pattern for the methicillin, oxacillin, penicillin G. It is most of 100%. But for the cefotaxime, ceftriaxone, chloramphenicol, vancomycin, and the gentamicin, we find some susceptible species of the Staphylococcus. Okay, some susceptible, some are in intermediate. That means unnecessary use of some antibiotic parenterally, it increase the resistance. Again, there is another study. See, these are the commonly used antibiotics, and there are many resistance isolates has been acquired. Have been acquired in the clinical research. So, whenever we are using for the treatment of the skin or some bone infection, kindly adhere the duration of treatment and optimization of the therapy, so it will give very good clinical improvement. And this is the last slide. I request all the veterinarians to follow the fundamentals of the pharmacology, whatever we have discussed, to increase your clinical cure rate. Thank you for patient hearing. And in today's session, we have seen some technical problem. And with this technical problem, we have completed our presentation. And we can start now the question and answer session.
Thank you, Dr. Jatin. Now, after the completion of the presentation, we are just started the question and answer session. Now I am request to Dr. Vilona. Dr. Vilona, can you hear me?
Yes, sir.
Okay. So I
Am I
request to
audible,
Dr.
sir?
Vilona. Yes.
Yes, thank you, sir.
So I request to Dr. Vilona, please start the question and answer session. Dr. Vilona.
Yeah, thank you, sir. So the first question by Dr. Krishnamurthy. What is the drug of choice in cases of retained placenta in bovines?
In retained placenta, what happens in the retained placenta? First of all, you have to retain the placenta, means you have to remove the placental debris. This is the first important aspect. This, if it is not possible, use drug like methyl ergometrin. Yeah, if your uterus is estrogen fine, please try to remove that thing. But unless and until these debris are present inside, it is very difficult to get good clinical cure. But if it is not possible, then first of all you have to use the drugs like metronidazole in combination of few cephalosporin. Yeah. Hello.
Yes, audible, sir.
Means
Yeah.
with the metronidazole and some cephalosporin will cover. This cephalosporin will not act in this debris. But I will not prefer to use some like enofloxacin or fluoroquinones in this condition. Only metronidazole will be having good anaerobic coverage. But if you does not have anything, then you can use this. But from my side, first remove all the debris, then you can use the cephalosporin with the metronidazole. One combination of fluoroquinone is available in the market, like cephalosporin tindazole. This also you can utilize for that treatment.
Yes, thank you, sir. The next question is by Dr. Jignesh. He has asked about reversion of resistance. If you could please explain it and explain the mechanism of action and what are the antibiotics where it has been observed.
Means revision of
resistance. Reversion of resistance.
Reversion of resistance.
Yeah.
Reversion of resistance is quite difficult. But something I had found through literature that it is, I can't say in today's date that it is impossible. This is biological system. Something can be invented and we can reverse it. But it is very difficult to reverse the, what we can say, resistance. Only thing is that complete removal of some antibiotic from prescribing in particular area. What happens? There, the organisms will be not exposed to that antibiotics. Ultimately, what happens? The organism like to think that now this antibiotic is not coming to fight with us. So they will modulate themselves. After 1, 2, or 3 to 4 years, what happens? Again, the organism will be susceptible. Okay? Hello?
Hello. Yes, sir.
Yeah.
Yes. Thank you, sir. Next question is, if we can use injection chlorpheniramine maleate to dissolve antibiotics, and whether, because sometimes mixing of these drugs will cause precipitation. So can we use this mixture?
Means mixture of antihistaminic and antibiotics.
Yes, antibiotics.
No. From my perspective, as a pharmacologist, never use two drugs because their formulations are different.
Okay. Yeah. Thank you, sir. Next question by Modi sir is, if can we use when we use higher doses of antibiotics, higher than the recommended dose, will it increase the effectiveness of antibiotics?
No, you should not go beyond the doses. Why? The scientific reason is that if you are going more, suppose it is beta-lactam or something, it is worth to increase the dose. Worth to increase means whatever how much amount you have to increase, it will not increase the killing rate. It will not increase the killing rate. Only you have to stick to the duration of the period. So I recommend again, never increase the dose. Go through the recommended guidelines But whatever the fundamental things are there in the pharmacology, for the time dependent, please stick to the T greater than MIC, that is duration of doses interval. Then it will more helpful to the veterinarians.
Yeah, thank you, sir. Next question is by Dr. Saurabh. Which antibiotic should be used first in case of cystitis in dog?
For the cystitis, I prefer mostly, in today's perspective, I preferred first, if you get the case, then go for the beta-lactam antibiotics like amoxicillin, sublactam. And if you does not find any cure, then you can use the levofloxacin.
Thank you, sir. Next question is by Dr. Singh. What are your views on the use of combination therapy of antimicrobial drugs in case of bacterial mastitis?
Combination of the drugs, whatever the combinations are available in the market that we are using, like cefoperazone, tazobactam, etc. This should be used. This combination should be used in the field condition because bacteria are gaining resistance. And most of the bacteria are producing enzymes. These enzymes are inactivating our antibiotics. So use this combination, like suicidal immune combination, to get a better cure rate. Or like suppose we are using streptopenicillin combination. This combination is used to expand the spectrum. But looking to today's thing, this beta-lactamase enzyme, which is produced by the bacteria, some extended spectrum beta-lactamase also as available, means it is seen in the literature, right? The organisms are producing. But in this such combination, like streptopenicillin, it is not covering this beta-lactamases. So kindly use this combination like cefoperazone, tazobactam, other amoxicillin, sublactam, like drug to cover up that spectrum.
Yeah, thank you, sir. Next question is by Dr. Jitendra. What about the alternative future resource to antibiotics?
In the future resource, this is good question. Now, in two aspects, I like to give this answer. One, the discovery of new compounds is somewhat delayed. Delayed means in the last 20 years, only 6 antibiotics has came in the market. But at the same time, organism has gained too much resistance and it has created a havoc for the medical practitioners like veterinary and the human doctors. They had confused us which antibiotics should be used. But if there some modalities can be standardized by using some ethno-veterinary practices along with this thing that can be substituted in the field practice and which can cover up the resistant thing. Because in ethno-veterinary practices, there are some secondary metabolites and these secondary metabolites are inhibiting or restricting growth of the bacteria by unknown way, which is not still explored by the scientist. So in this way, these two things, combination of some ethno-veterinary practices with this our traditional can improve the clinical cure rate. And second aspect, some drug discovery scientists are trying to get new compounds which does not follow our traditional mechanism, like some toxibactin, like E-resistin. These are the compounds which had come in the scientific literature, which have different mechanism of action rather than the traditional thing. Okay?
Yeah. Thank you, sir. Next question is by Dr. Jignesh. What is combinatorial antibiotic treatment and how it may help to suppress the emergence of resistance?
In the combinatorial antibiotic treatment, already just I had answered that. To suppress the resistance, you have to suppress the cause of the resistance. Like simple example, we are using tazobactam clavulanic acid as a pharmacological example of suicidal inhibition. What we do is we kill the enzyme and which will help helpful to our antibiotic, which is prescribed along with this clavulanic acid, and it will act in a clinical case.
Yeah, thank you, sir. So next question is, what about superbugs? How to tackle the emerging superbugs like multi-drug resistant, mycobacteria, etc.?
Now, superbug is a somewhat different condition. Still, scientists are trying to cope up this superbug. First of all, whenever this superbug appears in any clinical practice, don't blindly give any antibiotic. First of all, rule out the laboratory procedure, rule out this, which are antibiotic susceptibility. And second aspect is that whether whatever the MIC level we have got from the laboratories are achievable inside the biological system or not. If it is achievable, then apply the fundamental rules like time dependence or concentration dependent, and it can be prescribed.
Yeah. Thank you, sir. Next question is by Dr. Ashwin. What is the choice in mixed infection in mastitis?
In a mixed infection, the one of the thing one doctor has asked that what is combinatorial antibiotic treatments. Here what happens, for the covering mixed infection, generally we use the two type of antibiotic in a one preparation, like streptopenicillin. It has widened the antimicrobial spectrum. Such type of the preparation, if it is available in the market, we can use.
Okay. Thank you, sir. Next question is by Dr. Hita. In case we use antibiotics and there is absolutely no change in the disease condition for subsequent days, then how many more days should we use? Should we be consistent with its usage until we confirm that we are using the right antibiotic?
No, means if you are giving any antibiotic for 7 days, and if you are not getting any clinical cure or improvement, then you should stop the antibiotic, immediately get the samples and do the antibiotic sensitivity test, and then only you have to use the other antibiotic.
Yeah, thank you, sir. Next question is, they have asked to give a drug of choice for mastitis. Same goes again with antibiotics for ear infection as well as endometritis.
There is no drug of choice for the mastitis. Now, the era is changing. Now. There is no drug of choice for any infection, but looking to the symptoms and whatever accessibility to the laboratory diagnosis, if these two things has been combined together and applying the pharmacological aspects like this time dependent, concentration dependent, particular way of the treatment, like it is other tissue, blood, skin, if we apply the fundamental thing, then only it is possible to come some conclusion that this antibiotic is good for the particular condition. But in today's context, there is no drug of choice. I can say there is no drug of choice for the mastitis.
Thank you, sir. Next question is by Dr. Jignesh. Would you please enlist dose-dependent antibiotics and duration-dependent antibiotics?
Dose-dependent and duration means it is same thing. So duration means time-dependent and dose means the concentration-dependent. Same thing it is.
Okay, fine. Thank you, sir. Next question is by Dr. Nikhil. Is amoxicillin best suitable for chronic kidney disease cases?
What I am not...
Yes, I'll repeat, sir. Is amoxicillin best suitable for chronic kidney disease cases?
Chronic kidney. Here, for the kidney disease, first of all, you have to see that whether amoxicillin is reaching the parenchyma tissue or not. So, amoxicillin, from the literature, I know that it acquires the extracellular space of the kidney. But if try to see that this amoxicillin reach at a particular concentration in the kidney or not. What is the plasma concentration? in the kidney condition, because amoxicillin is totally excreted inside the kidney. We can see it's acquiring very high concentration in the kidney. When there is kidney disease, you should not use the drug which are excreting through the kidney. Otherwise, it will deteriorate more condition. Okay, so I have said that if you are using amoxicillin, if you want to use, fundamentally you should not use. You should use other drugs which are excreted through the liver passage, not like doxycycline. You should not use. But by somehow you have used in some clinical practice and you have failed, then this is the major reason.
Yeah, thank you, sir. Next question is by Dr. Gaurav. Is there any relation between steroid and antibiotic action?
Steroid and antibiotic action.
Yeah.
Steroid, this is antibiotic action. I can't say, but steroid, I can't compare between these two things. This is out of my coverage. Means I am somewhat, what we can say, ignorant. I am having some ignorance about this topic. I can't answer this thing.
No problem, sir. Next question is by Dr. Gajan. Sir, could we use bacteriophage in superbug?
Bacteriophage in superbug. Now, one main limitation for the bacteriophage therapy is that the bacteriophage, whatever means this is successful therapy, but you have to first isolate which bacteria is present in the infection, and based on that only you can use the bacteriophage. Based on that only. This is the most important hurdle. The multi-target bacteriophage, still it is not in the scientific literature. It is not in scientific literature.
Thank you, sir. Next question is, what is your opinion on the level of regulation in India on controlled usage of antibiotics in farm animals?
When we look into the regulation, there are many regulations framed by the government not to use this antibiotic. But when we see the field side, whatever the antibiotic used by the veterinarians, due to ignorance, some difficulty, they are using over the counter of some antibiotic. Few antibiotics should not be used in lactating animal, even though they are using without discard of the milk also. And there are strict regulations framed by the government today in India also. But we have to, what we can say, we have to adhere it and we have to optimize our therapy, whatever the armamentarium we have in our kit.
Thank you, sir. Next question is by Dr. Dinesh. If ceftriaxone 20 mg per kg, if it is given IV once a day, is it sufficient for a post-operative orthopedic surgery?
No. Ceftriaxone is, if you are giving IV, then it is not sufficient.
Yeah, thank you, sir. Next question is by Dr. Gaurav. Which antibiotic can we give after doing intestinal surgery?
Intestinal surgery, mostly we have missing in intestinal surgery. The one thing I have to take care that whenever you are doing surgery, please take proper hygienic precautions. Okay, antibiotics are generally not prescribed in the surgery cases, first of all, but we are giving to the animals. That is, the compounds like cephalosporins can be given, which cover most of the organism, which can cause some problem with this surgery.
Yeah, thank you, sir. Next question is by Dr. Jitendra. If I have asked your opinion, if antibiotic sensitivity test should be done before treatment of any infectious diseases to reduce treatment failure.
Means it is not necessary to every time ABST, but looking to the symptoms also many times we can get some clue that it is E. coli mastitis or somewhat. Suppose it is E. coli mastitis, means coliform mastitis, you should not use immediately you have to prescribe the antibiotic to cover the clinical conditions, because animal is suffering too much pain. Okay, but if you are interested, in such case, if you are interested, you have to take the samples and submit to the laboratory, and after the result arrive, then you can change the antibiotic. This type of the things can be done if you are interested in ABST.
Thank you, sir. Next question is by Dr. Khan. Is there any antimicrobial stewardship in veterinary practice? And if there is, what is the current status in India?
Antimicrobial stewardship means I am not knowing about this antibiotic stewardship that can be, that as this protocol has been given by the Indian government or any thing in veterinary practice. I am not knowing, but at a global level, most of the country has started these stewardship practices in the veterinary practices.
Yeah, thank you, sir. Next question is by Dr. Nikhil. Which antibiotic should we prefer in parvoviral infection in small puppies of 2 months of age?
Here the cephalosporins are safest drug for particular age, as a age specific 2 months of the puppy. But I will not prefer. Plus, please use the alternative to the antibiotics, that you should use IV fluids and NASIDs to cover up other things. But we should not prescribe antibiotic if the condition of dog is good. If the condition of dog is good, then you should not prescribe the antibiotic. Without antibiotic, you should try to cure it in such case.
Thank you, sir. Next question is by Dr. Dinesh. What is the choice of antibiotic in osteomyelitis, and what is the frequency of administration of the drug?
The first thing, that osteomyelitis, whenever occurs in any animal, the first thing that you have to think that first prescribe the antibiotic like cephalosporin group, and then you have to do, if the patient is indoor or something, it is coming regularly in the clinic, then please take the sample and check which microorganism is residing with it. Then according to that, you should apply the fundamental. Hello. Vilona, please ask the question.
Yes, thank you, sir. Yes, I'll continue, sir. So the next question is, so Jatin sir is here?
Yeah.
So the question was antibiotic choice in osteomyelitis and frequency of administration of drug.
Yeah. In osteomyelitis, I prefer to get the ABST in a very short time after the confirmation of osteomyelitis, and then you should prescribe the antibiotic. Initially, for coverage, broad spectrum can be given but later on the specific antibiotic should be given. But the one thing is that the long duration, the fundamental rules should be applied. If you are using cephalosporin, use at 8 to 12 hours, and if you are using fluoroquinones, you should do 24 hours. The time of the dosage interval should be accurate to get the good results.
Yeah. Thank you, sir. Next question is by Dr. Gaurav. Can we use cephalosporin and fluoroquinolones with each other? And if yes, what will be the mechanism of action?
Both cephalosporin at a time? No. It is waste of the drug. We can't use.
Cephalosporin and fluoroquinolones together.
Cephalosporin and fluoroquinolone.
Yeah.
Means what happens? Both the drug are acting on the same phase of the cycle. Same phase of the cycle. That means there is a life cycle of the bacteria, and that both are acting at a, when bacteria are totally metabolically active. Both are targeting different way. But somehow still the scientific literature has not proved that whether the synergy can occur, a addition can occur between these things. So it is worth to use these two antibiotics in this case. Means there is no additional advantage. If you find any advantage in a scientific literature that particular cephalosporin, particular fluoroquinone, if it is clubbed together and given, and it shows the synergy for the bacterial killing, then only you should use. Otherwise, it should not be used because both the drugs are acting on the metabolically active replicating bacteria.
Thank you, sir. The next question is by Dr. Nikhil. In case of parvoviral infection, there will be chances of sepsis in intestine. So total leukocyte count will rise. So is there any possibility we can go ahead without the use of antibiotics?
It is very difficult if the sepsis has occurred. Then it is very difficult to prescribe the drug. Means in the sepsis, what happens? Bacteria will reside, and we have very less antibiotic which are active on this condition. Without antibiotic, it is not possible in that case.
If ABST is not available in field level, what should we do?
The same thing I had seen from the clinical point of view. How would you diagnose the case? And if you are possible, then this infection is through gram negative or gram positive. If this much knowledge you have, you can acquire, then you can treat in that respect.
Yeah. Thank you, sir.
Okay, Dr. Vilona.
Yes, sir.
Now, this would conclude the question and answer session. Hello, Vilona?
Hello, yes, sir.
Yes, sir. Now conclude the
Yes, sir. That's the last question, sir. There's one last question.
answer session. Okay.
Yes, sir.
Thank you all the
Yes, sir.
participants, and thank you, Dr. Our participants. And now I thank to Dr. Ashwin Thakur, sir. Today, Dr. Ashwin Thakur, sir, is with us, sir, on online. Dr. Ashwin Thakur is a former principal and dean of the Veterinary College, Anand, and he is giving a best compliment to Dr. Jatin on this Guru Purnima days. Thank you very much, sir. We all are very fortunate because you are joining with us on this auspicious day. Thank you, sir. Also, Dr. Jayesh Patel is with us, and he is also giving a best wishes to us. So, at the last of today's webinar, I request Dr. Deepak Suthar, sir, organizing secretary of this the webinar series, for his word. Dr. Deepak Suthar.
Thanks to today's speaker, Dr. Jatin Patel. Some nice presentations and very well explains and give each and every questions the answers to satisfy all the participants. Now I am thankful to our Honorable Vice Chancellor, Dr. Sunil Chaudhary, sir, to give the permission for this webinar series. I'm also thankful to the Dean and Principal, Dr. V.B. Kharadi sir, to give the valuable suggestions regarding this webinar improvement each and every time, sir. Thank you, sir, Kharadi sir. Now I'm thanks to the Director IT, Dr. Pandya sir from the IT department, provide the nice digital platform for this webinar series, and I am thankful to the team of the IT teams. So each time ready for the coverage and the provide the digital platform nice. I'm also thankful to the Dr. Lalit Modi, co-organizer secretaries, so each and every time with me. And finally, I'm once again thanks to the today's speaker, Dr. Jatin Patel, give the nice presentations and excellent explanation of the today's webinar. So thanks all the participants join with us. The next week, I will come with the new topic with the new speakers. So thanks now on the end of these sessions. Thank you very much to all the participants.